Hello, everyone. My name is Donna Shaka, and I am the National Community Outreach and Education Manager of the American Liver Foundation. I want to welcome you to today's webinar. The American Liver Foundation is the nation's largest nonprofit serving people with liver disease. We provide a voice for patients with liver disease and their families through education, support, research, and advocacy. The ALF's mission is to promote education, advocacy, support services, and research for the prevention, treatment, and cure of liver disease. I want to thank Bristol Myers Squibb and Merck for their sponsorship of today's webinar. And we also want to thank Dr. Ramya Thota, who will be sharing her expertise about immunotherapy during our webinar. On the next slide, I just want to go through a few details about the webinar. Dr. Thota will give her presentation while everyone remains on mute, but there will be a question and answer session during the last portion of the webinar. The Q&A will be conducted via the dialog box that you should see on the upper right-hand side of your computer screen. And you can, I know on this graphic it says questions, but I think you're going to see chat. So please enter your questions in the chat box and those will be answered at the end. If you don't see the dialog box, there should be an orange arrow that you can use to expand that window. So please just type your questions in there at any time during the webinar and they'll be answered at the end. So I'd now like to introduce our presenter for today's webinar. And there she is. Dr. Ramya Thota earned her medical degree from Guntur Medical College in India. She did her residency in internal medicine at Creighton University Medical Center in Omaha, Nebraska, and a fellowship in hematology and oncology at Vanderbilt University School of Medicine in Nashville, Tennessee. She is board certified in internal medicine, hematology, and medical oncology. She's currently an assistant professor and practicing physician at Intermountain Healthcare in Utah. So I think we are in very good hands with Dr. Thota here. I'm going to let Dr. Thota go through the objectives for today's webinar, and this is what we hope that you'll all gain from listening to her presentation. So I'm going to turn it over to her, and then we'll do the Q&A when she completes her slides. Dr. Thota, welcome.
Thank you, Donna. Thank you so much for American Liver Foundation for giving me this opportunity to talk about immune therapy in liver cancer, which is an emerging and very hot topic in the field of liver cancers. So just want to go back and briefly talk about the objectives of this talk. I will be talking about the immune checkpoint inhibitors, and then I will be giving a brief introduction about what a PD-1 inhibitor is and CTLA-4 inhibitors are, and when exactly we might be using these drugs in the treatment of liver cancer. I will be ending my talk talking about the common side effects of immune therapy and how we will be managing those side effects. Before I go into in detail about the treatment or use of immune therapy in liver cancer, I want to give a brief introduction about the types of the liver cancer. You all know that liver is one of the largest organs in our body, and there are different types of cancers that can arise primarily within the liver. The most common one is the hepatocellular carcinoma, or commonly referred to as a primary liver cancer. The other types of cancers can be bile duct cancer, angiosarcomas, or hepatoblastomas. Hepatoblastomas are commonly seen in children. For the sake of this talk, I'm going to focus mostly on hepatocellular carcinoma. And in near future, I'm going to use the word liver cancer in replacement for hepatocellular carcinoma. As you can see, that the total number of cases of liver cancer have been steadily increasing over time. In fact, since 1980, we can say that the number of new cases have almost tripled and the number of death rate also has doubled, suggesting a huge cancer burden in the entire world, and overall liver cancer is the fourth most common type of cancer worldwide. Now, briefly talking about the risk factors that lead to development of liver cancer. Hepatitis is one of the most common risk factors, followed by alcohol. And lately, we are seeing a rise in incidence of non-alcohol related liver cancers, especially related to obesity, diabetes, can also lead to cirrhosis, which is scarring of the liver, and eventually developing into liver cancer. Oftentimes, it is accumulation of more than one risk factor that leads to the development of cancer. When it comes to the treatment of liver cancers, unlike many other different types of cancers, it involves really different types of doctors, a multidisciplinary team of doctors combining together to come up with the best possible personalized treatment for you. And it depends upon the treatments or variety of treatments. Depending upon the location of your cancer, how much of your liver is affected, whether the cancer has spread or not, and based on your preferences, the treatments can vary from either going through a transplantation, surgery, or involve some local treatments, or can involve systemic treatments, which can be either targeted treatments for the cancer or can also involve recently immune therapy. It is important to note that only transplantation and surgery are the main treatments to completely get rid of or eliminate this cancer. The rest of the treatments are mainly involved in slowing the cancer and looking at improving the quality of life. For the sake of this talk, again, I'm going to mostly focus on immune therapy piece of it. And the field of liver cancer, especially when it comes to the newer drugs, it has been really evolving rapidly in the past 5 years, I will say. For the first time in 2007, FDA approved a drug called sorafenib, which you all might be known as Nexavar, in 2007. Since then, a number of studies were conducted and a number of trials were done with no benefit with any of the agents. Until about 2017, almost 10 years later, we found that regorafenib was another drug that can work. And since then, there has been at least 9 different agents that have been currently approved in the treatment of liver cancer, and out of which 4 of them are immune therapy drugs. Here, I will be talking mostly about these 4 drugs. So moving gears and now talking about what are the immune checkpoint inhibitors. It is often referred to as immune therapy or biologic therapy in general. What it means is that these are a type of cancer treatment that utilize your own body immune system to fight against cancer. And frankly, since the immune therapy first got approved over the past few years, it has really changed the entire field of cancer, not only liver cancer, but variety of other cancers. Now, how do these immune therapy drugs work? They mainly work by attacking or inhibiting what we call as immune checkpoints. So what are the immune checkpoints? Immune checkpoints are nothing but they are the proteins that are present on top of our immune cells and on top of the cancer cells that actually prevent our own immune system to recognize the cancer cell and attack it. So right now there are 2 different types of checkpoint inhibitors that are currently available. They're commonly referred to as PD-1, PD-L1 inhibitors, or they can also be referred to as CTLA-4 inhibitors. Going in depth into what are these PD-1, PD-L1 checkpoints. As you can see in this figure, the red cell is our body's immune cell. The protein that is present on the top of this immune cell, also called as T cell, is called PD-1. At the same time, you can see there is a green color protein that is present on the normal cell or a cancer cell. That protein is called PD-L1. So normally in our body, our immune system, when it finds the cancer cell, this PD-1 binds with that of PD-L1, and as long as that linkage happens, technically the immune cell cannot recognize the cancer cell. So the cancer cell will escape from the immune cell. Now going to the different picture, as you can see here, you can see the tumor cell and you can see the T cell or the immune cell. Normally, when the immune cell is coming close to the tumor cell, this PD-1 binds to the PD-L1. As long as that binding happened, immune cell cannot do anything to the cancer cell. As soon as, now coming to the picture on the right, as you can see, the red triangle is kind of like a PD-1 inhibitor. As soon as that inhibitor binds to this PD-1 receptor, you can see that the immune cell can start recognizing the cancer cell as foreign and can kill it directly. The same way, either you can block the PD-1 with that red marker, or you can block the yellow with the PD-L1 inhibitor, and either you block PD-1 or PD-L1, the final outcome is the same, which is that your immune system starts recognizing cancer cell and kills it. Now coming to what is the CTLA-4 inhibitor. So similar to the PD-1, PD-L1, as I mentioned, which are the proteins that are present on the immune cell and the normal cell, CTLA-4 is another type of protein that is present on the cancer cell. Normally, when CTLA-4 is kind of like an off switch, as long as the CTLA-4 is there, immune system cannot recognize the cancer cell. But as soon as you block the CTLA-4 with this antibody, you start recognizing, the immune system starts recognizing the cancer cell and leads to its cell death. There are a number of these immune checkpoint inhibitors that are currently approved in the treatment of variety of cancers. Here I listed only those drugs that are currently approved for liver cancer. For the first time in 2017, FDA approved this first drug called Nivolumab, also called as Opdivo, which is a PD-1 inhibitor. Since then, you can see that almost 5 different agents have been approved by FDA, including most recently combination of immune therapy drugs, especially CTLA-4 inhibitor in combination with the PD-1 inhibitor. These are all the drugs that are currently available in the treatment of liver cancer. Now, let's talk about when do we use these PD-1 inhibitors. If you remember in the beginning of the talk, I mentioned about the different types of treatments that are available for liver cancer, which includes transplant, surgery, or local treatments. So in order to be eligible for these immune therapy drugs, first of all, the patients should have advanced liver cancer. They should not be eligible for transplant or surgery or any local treatment options. And also important to note is that they all should have a good liver function and they should be in general in good health. And FDA, when it approved these PD-1 inhibitors, they approved it with a clause that it is only approved for patients if they have received prior sorafenib. That means all the patients with the liver cancer, once they are considered not a candidate for any of these treatment options, then they receive sorafenib as their first treatment. And when they progress on that, then they can receive these PD-1 inhibitors. Right now, there are 2 PD-1 inhibitors that are available for use, which are Nivolumab and Pembrolizumab. And again, Nivolumab is approved only after the treatment with sorafenib. It is not approved in people right at the time of diagnosis. So this, as I said, it was approved in 2017, and this approval is based on Checkmate study in which 154 patients were received Nivolumab, which is a PD-1 inhibitor. It is given intravenously over 30 minutes every 2 to 4 weeks. And what they found was that those people who got this PD-1 inhibitor had a chance of shrinking of the tumor in approximately 1 in 5 patients. And these shrinkages usually happen within the first few months. More than 90% of the patients, if they are having a shrinkage, it happens in the first 6 months. And up to more than 50% of the patients, these tumors continue to shrink even at 12 months and beyond. Unlike chemotherapy, immune therapy is really unique in its own way, where it can help some patients while it doesn't help other patients. For example, Some of the cancers start growing within 3 months of giving the treatment, while other patients, the tumors can be shrinking and not growing and get some kind of benefit from this treatment for over 2 years or longer. Now switching gears and talking about the combination treatments. Coming to the combination treatments, always we say that the more the better in cancer, but the more the better in terms of benefit, but more comes the toxicities or the side effects from these drugs. For example, this combination of PD-1 and CTLA-4 inhibitor, the combination has been approved in March of 2020 based on this small study that was done in approximately 50 patients with the advanced liver cancer in whom they have received this combination therapy every 3 weeks for 4 doses, followed by this single drug every 2 weeks. What they noted was that compared to, as if you remember when I mentioned about PD-1 inhibitor, it benefits or like the probability of tumor shrinkage is seen in about 15 to 20% of patients. That is approximately 1 in 5 patients. However, the more the better, right? So the combination drug seems to have more benefit where 1 out of 3 patients have a probability of tumor shrinkage. And it is quite impressive to see that about half the patients are alive at 2 years, and some of these responses or the benefit seem to be lasting really long term. But again, same as with any other immune therapy, you really don't know who are the people that benefit from this drug. While some people benefit over 3 years with this combination, in some patients it grows within 3 months. I truly wish that we have a marker that can help us identify who out of these 100 people that are going to benefit from this immune therapy. Now switching gears and talking about the new kid on the block or kind of like the new treatment that is recently approved by FDA in the treatment of liver cancer that has revolutionized the treatment of liver cancer forever, I will say. Because for ages or until September 2020, any patient that got liver cancer that is not eligible for transplant or surgery or treatments, their only go-to drug is sorafenib. And coming to September 2020, the FDA approved this new immune therapy drug for patients even if they haven't received prior sorafenib. Now, briefly, again, I want to go over a little bit detail of how this PD-L1 works. You have seen the previous figure where I mentioned PD-1 combines with PD-L1 and it prevents your immune system recognize the cancer cell. So it's inactive. Now, as soon as you block your PD-1 and PD-L1, you start realizing the immune system starts recognizing the cancer cell and kills it. Now, how they approved, the FDA kind of approved not just the immune therapy, but immune therapy in combination with that of bevacizumab, which is a targeted therapy for people with liver cancer who have not received any previous cancer treatments, especially using medications. That means even if you haven't received prior sorafenib, you will be eligible for this treatment. And compared to those who received sorafenib, this combination led to increase in survival and people were living longer, their cancer is not growing. And on the top, the most important thing was that people had a better quality of life among those who received this combination compared to those who did not. Now, it is important to know about the side effects with the combination therapy. Most common side effects that we worry about, besides the immune therapy side effects, which we will be talking about shortly, major risk factor or major important thing we need to take care of is making sure that people are not bleeding. Because this is a targeted therapy that is combined with immune therapy, there is an increased risk of bleeding. Therefore, every person need to make sure that they have their endoscopy done prior to receiving this treatment, at least within the 6 months time. Now, switching gears and talking about what are the common side effects of immune therapy. and how do we manage them? Immune therapy side effects work very differently than that of chemotherapy. Sometimes I can tell you that patients walk to my clinic, get their immune therapy, and they go home and they come once a month, get the treatment, no side effects at all. At the same time, I have seen people that come to me, get one dose of treatment, and have a real life-threatening side effect. That can include affecting any organ system in our body. If you remember the way the immune system works or the immune therapy works, it is a medicine that is given into your veins and it goes and activates your immune system. Once your immune system is activated, we hope that it starts killing the cancer cells, but in process of killing the cancer cells, it can sometimes, by mistake, starts killing your normal cells. That can be a normal liver, normal heart, normal lungs, normal colon, or brain, or any part. Sometimes it can be overwhelming when you look at the side effect profile of immune therapy because it can be wide variety. But that doesn't mean that every person gets all the side effects. It is not. And key to note is that many of these side effects that happen with immune therapy are treatable. We can treat them. But important is that need to be aware of what are the side effects, when do you need to call the doctor, and important is to identify them early and do the treatment early. And the problem is that you never know when these side effects happen. That can happen right when we are giving the infusion, or it can happen months later or years later. Even after you stop the drug, you might end up having a side effect. But again, the probability of having these side effects depend upon what type of immune therapy you are getting, whether it is one drug, one PD-1 inhibitor, or is it the combination of inhibitors. Now let's talk about the Nivolumab, which is an PD-1 inhibitor. The most common side effects, I think almost half the people do experience some kind of mild fatigue. Sometimes people might come with a new rash or itching. It is rare to have a serious side effect. I always tell that approximately 1 in 5 people might experience this serious side effect. Oftentimes, the serious side effect includes increase in the liver enzymes. However, it can happen in which their lungs got affected, in which patients might present with cough or shortness of breath, or sometimes their liver is affected, where they might present with jaundice, or some people might have their colon affected, where they might come in with diarrhea or constipation. Thing is that, again, not every person gets all the side effects. Important to note is there is a possibility of a life-threatening side effect, but as soon as we know it, if we can give them the steroids, the side effects will be reduced or minimized in majority of the patients. Approximately 5% of the patients, that means 5 out of 100 people, have a chance of receiving a steroid because of a serious side effect from the treatment. As I said, most of the times, once we give the steroids, we are able to minimize the side effects and get them back to their normal self. Now, coming to the combination drugs. What happens with the combination drugs is the side effect, the probability of shrinking, as you heard before, the combination of CTLA4 and the PD-1 inhibitor together, they have a higher chance of getting a benefit. That means from 15% of people benefiting, it's almost double that 30% of the people do get the benefit with this combination. However, the side effects are also kind of more. So when you are getting a combination of CTLA4 with the PD-1 inhibitor, there is more than half chance that you will end up having some form of a serious side effect. And most of the serious side effects often involve increase in the liver enzymes. But again, that can vary anywhere from having a bad side effect in terms of attacking the lungs or attacking the liver or attacking the colon. But forgetting about the serious side effects, majority of the people that have mild side effects will be just the fatigue, some rash, and some nausea could be the side effects. But as soon as we know that there is a new symptom or a worsening symptom, we would like to get started immediately on the steroids with the hope to mitigate all these side effects and treat them. Now, Talking briefly about the steroids. What are the steroids? Steroids are nothing but they suppress our immunity. They decrease the number of immune cells in our body. And in process of which, again, if you understand the mechanism, immune therapy side effects are because your own body's immune system is attacking your normal body. So if we can suppress that immune system with the use of the steroids, especially they work really well if you can start them early. That's why it is important to contact the healthcare provider with any new or worsening symptoms. But just like any other drug, even steroids come in with a set of side effects. Oftentimes, when we give steroids, the common thing that people feel is they feel really high, as if like they could climb a mountain or something. But other side effects that can follow along will include their appetite will be better, they will be gaining weight because they retain the water, their blood pressures can be high, their blood sugars can be high. So when you're started on the steroids, the healthcare provider will be watching you closely for your blood pressure, for your blood glucose, and making sure that the side effects are slowly reducing each day. Oftentimes, when we start the steroids, our expectation is that the side effects go down within 24 to 48 hours. Although the side effects go away within 24 to 48 hours, it is important that we don't stop the steroids right away. The reason is that if you stop the steroids right away, there is a chance that you go into withdrawal from these steroids and the symptoms can recur right away. That's why you want to make sure the steroids are tapered slowly over a course of 4 to 6 weeks or longer, depending upon the severity of the side effects. And as I mentioned, usually our expectation is once we start the steroids, we expect the side effects to go down within first few days. Sometimes the serious, again, if you talk about the real serious side effects, the serious symptoms may not have improved within 2 to 3 days of treatment. If that happens, or the patients end up requiring an ICU level of care and the symptoms are not going away, for example, their shortness of breath is not going away, they're on oxygen, or they end up requiring an intubation or things like that, that is a serious side effect at which we need to increase their immune suppression beyond the steroids, where we might be including other forms of immune suppressive agents. So this is how we manage the side effects. When patients come in with a mild symptom means their liver enzymes are only a teeny bit increased. Like for example, instead of 2 times normal, they went to 3 times normal. If it is mild, we are only going to hold the immune therapy and we are going to support them if they have any symptoms. But if the symptoms are moderate, that means they are having cough, they are having a shortness of breath, and now they are requiring an oxygen. If they are getting more of the moderate side effects where they are to the point of requiring an oxygen, then we would like to start them on steroids right away. Sometimes the symptoms can be severe. If they are too severe, that means they end up in the ICU or they end up in the hospital, then we will never want to use the immune therapy drug again. We want to permanently discontinue these drugs forever. And important to note is that we expect the side effects to go away within first couple of days of starting the steroids. And if that does not happen, we need to increase the immune suppression to more stronger immune suppressive agents. So in summary, I would like to mention that immune therapy is a safe treatment, very effective treatment for a small group of patients with liver cancer. Especially if I wish that we know who are the people that benefit and who are the people that get the side effect, but we don't know that. But it is important to note that both the PD-1 inhibitor alone is effective as well as in combination with CTLA4 inhibitor. And key to remember, there is a potential chance of rare but a serious adverse event, and that's why it requires a close monitoring. Some patients derive very long-term benefit while others don't derive benefit. But key is that compared to years ago where we have only sorafenib as one drug, you can see that these immune therapy agents are giving a better quality of life and they're improving the lifespan of these patients. but a small group of patients get that long-term benefit and a small group of patients don't get any benefit at all. It is a really important, and there is a critical need to find the markers to find out who respond and who gets the side effects. There are more and more trials that are going on in combination of immune therapy with more targeted therapies. Right now, we do have approval of atezolizumab, that is called Tecentriq, with bevacizumab or Avastin in patients with newly diagnosed liver cancer. But there are more and more combinations with the PD-1 inhibitors and other targeted therapies that are in the horizon. And I'm very excited to see the entire field of liver cancer changing with discovery of these new drugs. Now we can go to the questions.
Thanks, Dr. Thota. We do have several questions here. We're going to just show this slide for the remainder of the question session, just so that you can take down the information for our website and other resources here. So that's just for your edification. The first question is there a correlation between autophagy, I hope I'm saying that right, and immunotherapy? More specifically, can someone who is undergoing immune therapy for hepatocellular carcinoma also do fasting to activate autophagy?
That's a great question, Donna. And I think right now the field is evolving so much and people are learning more and more about autophagy and immune therapy. How would I say is that right now the data is not mature enough that I would advocate or recommend my patients fasting right now. It is still in kind of very early stages to know whether it really benefits or not. So again, the field is evolving. I won't be surprised if the answer to this question is different 6 months from now or a year from now. Right at this point, the data is not mature enough for me to recommend or say that fasting will make a difference with immune therapy, though.
Okay, the next question. One side effect of immune therapy is also immune therapy-induced hepatitis. Do you have any comments on that?
Yes. So instead of using the word hepatitis, I mentioned about elevated liver enzymes. This is the most common side effect that was seen in people that when the immune therapy first came out. And this is the most common side effect we see even in the patients with the liver cancer. But it is important to note that the immune-mediated hepatitis, it can happen. It can be life-threatening in some people where we have to start on immune suppression and everything like that. But it's 1 out of 5 people, there is a probability of that happening, but 4 out of 5 people, it won't happen. So that's why initially when this immune therapy, when the trials are going on about immune therapy in the liver cancer, everyone is so scared. And how are we going to deal? Already people have a hepatitis, or already people have an underlying elevated liver enzymes to begin with. And you are trying to give someone that is susceptible to the hepatitis or elevation of liver enzymes, and you are trying to give them an immune therapy drug. The risk often is there. That's why we are very careful and selective in selecting the patients for immune therapy where we want or we would like the patients to have a good liver function. That's the only indication where FDA approved this immune therapy, where patients should have a good liver function, so that in case you give the immune therapy and potentially they had a major hepatitis flare, or whether they had an elevation of liver enzymes as a side effect from the immune therapy, they still can do okay. That's why they do not take people with very severe liver function.
Understood. The next question is, why is sorafenib treatment required prior to PD-1 inhibitor treatment?
Excellent question. Actually, that was a kind of question we often struggle with in tumor boards or talking to other physicians. So I want to just tell you briefly how these clinical trials work. So for years together, we never had any drug other than sorafenib. So when these immune therapy is being tested, all the studies were done after people who have received sorafenib, because none of the patients are willing to take an experimental drug when you already know that something works. So just for the feasibility sake of the clinical trials, they often try to, when the drugs are coming out into the market or when the trials are being conducted, often they are conducted in patients who have no other treatment options, and slowly they bring it forward. So in 2017, for the first time when we got this PD-1 inhibitor approved, those trials were conducted in the people who never received, who already have received sorafenib. That's why the approval was after sorafenib. But more and more we realize that it is safe enough. Immune therapy, there is a promising signal in liver cancer. It is working really well. Slowly the clinical trials and the research is bringing on to the early phase on to before sorafenib. That's why right now, even though the PD-1 inhibitors were tested only after sorafenib, the newer PD-L1 inhibitors and the combination drugs are being tested in people even without receiving sorafenib. So now we do have approval before sorafenib treatment with a PD-L1 inhibitor.
Thank you. The next question is, what are some of the absolute no-nos when on immune therapy for hepatocellular carcinoma? Which, if any, foods or dietary supplements should someone avoid while on immune therapy?
This is another very good question, Donna. So absolute no. So immune therapy we do not give for people if they are receiving an immune suppressive medication already. For example, if a person is already taking steroids because they have Crohn's disease or they have a rheumatoid arthritis, some form of an autoimmune disorder where their body already has a susceptibility to attack their own body cells, and they are already on certain medications like steroids, we do not want to give immune therapy for those patients. When it comes to certain types of foods, there are definitely no restrictions on any types of foods or any types of dietary supplements that we need to avoid on the immune therapy. But be cautious about the medications though, especially when it comes to something that is suppressing the immunity in terms of steroids. You want to avoid the steroids while you are on immune therapy unless it is really indicated for the side effect.
This isn't one of the questions that's here, but it's in line with what that question is. One of the things we get asked a lot about is people who want to take liver cleanses and body detoxes, and I think I would like you to address that, because people see something that says all natural cleanse or all natural detox, and it seems like if you're on a therapy like this, that should be something to always ask the doctor about and not just take it at will. Is that correct?
That is correct, Donna. Really, I do see a lot of patients believe in the liver cleanse or in general colon cleanse and things like that. As a physician, my strong recommendation is to avoid any of these natural supplements. The main reason is that we don't know. We don't know how those are going to react with immune therapy as such. Again, if you go back to the mechanism of how these treatments work, probably there should not be any interaction. However, some of these cleanses might also affect the liver or might also affect the colon, and we don't want to complicate which of these is causing. So I personally would completely recommend, when you're on immune therapy, in order to not to complicate, avoid any of these medications.
Okay, thanks for clarifying that. Another question that we have here, and I hope I say these things correctly, is Tecentriq and Avastin considered a combination therapy? And thereby, if they are, would they increase the chances of serious side effects, such as increased liver LFTs? And once started on steroids, could a patient go back on immunotherapy?
Excellent question again. So yes and no, the answer is. So if you're on combination Tecentriq and Avastin and there is a mild increase in liver enzymes, that means it only went up by 3 times normal, then what we do is we stop the treatment for a little bit and see if it will come down on its own. We also want to make sure there is not any other causes for the elevation of liver enzymes. Just as you mentioned, Donna, we want to make sure they are not taking any herbal supplements or any other over-the-counter medications or cleanses or anything like that. And once we rule out all other possible causes, and we really believe that it is in fact the Tecentriq or immune therapy that causes the liver enzyme elevation, depending on the severity of that elevation of liver enzyme, we make the decision. For example, it only went by mildly, just few points, then it's okay to try to re-challenge them after the liver enzymes come back to normal. However, if they went on steroids, that is the question is that some people have a low threshold to start the steroids early. So if the steroids were started and they were able to get off the steroids very quickly in a span of like few weeks, then, and considering there is no other alternative treatment, it is okay to re-challenge, but be very cautious that if you re-challenge after after giving the steroids and knowing the patient had a side effect with immune therapy, you really want to check those liver enzymes very closely, like within few days or even like every other day, to make sure that the liver is not getting affected again. Because sometimes if there is a tendency for the immune system to cause the elevation of liver enzymes, and when you re-challenge them with immune therapy, that can be very severe. That's why you want to monitor them closely. But if it is so severe that liver enzymes are like 10 times the normal, and they're like super high, and they ended up requiring much more beyond steroids, then definitely it's a no-no that we do not want to re-challenge with the immune therapy at all. And one other key thing I want to mention is that some patients, this is just an anecdotal observation though, is that people who get benefit with immune therapy, once you activate the immune system, even though you're not receiving the drug, for some patients that benefit seems to be lasting longer. Even though you don't receive the drug, the medicine has already gone to the body and it has done what it needs to be done.
Thank you. The next question, it's very brief, so I think I know what they're saying. It's just saying low platelets, any restriction? So I think they mean if you have low platelets, is there any restriction for immunotherapy?
Great question. All the studies that were done in the immune therapy space, they have a set criteria depending on which clinical trial you are looking at. They wanted to use, they want to use a platelet count of 70, or some clinical trials have allowed it up to 60. And I face this all the time is patients with cirrhosis have a low platelet count to begin with. So some of the patients have a platelet count of 50 or like that. I try to do immune therapy for people with a platelet count of around 60 is what my threshold is, and that's what most clinical trials have done. If the platelet count is really low, like 30, I will be nervous. I do explain that itself explains that their liver is not doing well. So we need to figure out why the platelet count is so low before we start the immune therapy. Because remember, immune therapy is only approved for people with good liver function. So yes, there is a threshold of 60 or 70, but if it is something else causing the low platelet count other than the liver, we have to weigh the risks and the benefits with that.
Thank you. The next question is, can immune therapy be used in patients with non-alcoholic fatty liver disease?
Wow, I feel like I get a lot of smart questions actually. It's like everyone is so well educated or like so well informed about this treatment. That's a great question, and I think that's what the field is moving around right now. There is no data to say that immune therapy can make a difference in non-alcoholic fatty liver disease by any means. There is no data for me to share, but we never know. In future that might come up. Right now, immune therapy is still being explored in the field of cancer. So without a liver cancer, just for non-alcoholic fatty liver disease, I don't think there is any data. But if you have a non-alcoholic fatty liver disease and ended up having a liver cancer, yes, definitely. So we do know that based on the underlying risk factor that led to the liver cancer, we do know that immune therapy does work for people with non-alcoholic fatty liver disease who develop the liver cancer, but not without cancer.
Thank you. The next question is, my liver function tests were close to or below 200, but the doctor started the steroids yesterday. I am on a clinical trial, so I'm not a classic patient. Any comments on that?
Definitely. So yes, 200 is a little bit higher. So especially thank you for letting me know that you're on a clinical trial. Every clinical trial has a set criteria that they establish before they go on to the clinical trial, and they provide guidance. For example, most of the clinical trials, they say that if your liver enzymes are more than 3 times upper limit of normal, then we would like to give them steroids. That some people said that as a criteria on each clinical trial, depending on which trial that they are going on. So because it is 200, the normal, usually depending on which lab you go to, normal is around 40. So that tells me that it is more than 3 times, which is more than 120. So that makes sense that probably based on that clinical trial, they started on steroids. On the same note, the clinical trial will also set forth some criteria to say that if you are able to get off some steroids in certain time period, they might be able to let you back get the drug. So it depends on the trial criteria for sure.
Thank you. The last question that we had, somebody wanted the slide deck sent to them. This webinar rather, is being recorded, so it will be on the American Liver Foundation website. So when the link is ready, it will be on our video resource library. So if you go to the website that's on your screen right now and go to liverfoundation.org and go to the resource library, it will be posted on the liver cancer page. And people can visit that resource center under video library, so you can access the slide deck right from there. So this will be visible to you if you want to re-watch it or share that link with other people. We would certainly welcome you to do that. So Dr. Thota, thank you so much. This was a really wonderful presentation, and we know you're busy, so we appreciate you taking the time to do this. We want to again thank our generous sponsors, Bristol Myers Squibb and Merck, for their support of the webinar. And we also want to extend our thanks to everyone who joined us for this webinar today. Please do share the information where people can find this webinar once it's online. Give us a couple of days for that. We hope it was helpful. Don't forget that you can visit our website and also our national helpline at 1-800-GO-LIVER if you need any other information. This brings our webinar to a close, so thank you again. Everyone take care. Bye-bye.